will benefit.
Okay, you got to do a good job now because that's what people are going to learn from.
Yeah, now the pressure's on. I don't know if I have it, but so if we're starting out and training at CZ, we would set the reward about 12 to 15, set an inhibit at 2 to 7 and another inhibit at 22 to 36. Train at that for a while, see what we get. And then what do we set the percentages, that little bar?
Yes. Okay.
That's also confusing.
Yeah. So, okay. And that's confusing for me because it's the exact opposite of what I learned and I still am stuck with what I learned. So, I got this written down by my BMedic equipment and I'm not in that office. I don't want to tell you wrong. I want to see if I have it written anywhere. Okay, the low inhibit, 25%. Okay, and that means 25% of the time, the low inhibit is going to exceed the threshold. So what you want to do with inhibits, you want them, you're teaching those brain waves to get smaller. And when I say get smaller, you're not going to see within one session if the power is 22 microvolts, is it going to go down to 10? We're not talking about that. We would like it if it goes from 22 to 20 or 19. That's smaller. Okay, but you set the low inhibit at 25 because the low inhibit is easier to train than the high inhibit. Okay, and then the high inhibit is set, am I getting this right, at 10%?
So Angelica, I was totally confused when we talked about BMedic, and it was the opposite for me. So
that's what
yeah. So with Eager, I set, like, I might set 20, I might set like 20, then 70, and then 15. But I think BMedic is the opposite of that. So it would be 80 and like 90 for the high inhibit, and then
you're right, Ginny. Yeah.
30. It was totally confusing until I went, wait a minute, it's just the opposite of what I know.
I know, sorry. Okay, but it's still okay. So instead of 25, it's 80%. And that would mean 80% of the time it's staying within the threshold and 20% of the time going over the threshold. And you want it to stay within the threshold. And I'm going to go to the other inhibit, as Ginny said, 10%, 90%, because 90% of the time you want it to stay within the threshold. And then the reward is the same, and that's at 65. I'm going to write that up and send it out because obviously you see I'm confused by it. And I don't want to have confused you guys more. But it's 80, 65, 90. But I'm going to write it up. Okay, so I got two things, write up thresholds and get Mitch to send the stuff.
So Angelica, could you just like say one more time, if we set the threshold at like 80%, so 80% of the time we want what, and then 20% of the time we don't want what, or the opposite. Can you just like say that again? Because I have such a hard time keeping that in my head.
I know, I do too. So if you're setting an inhibit, what you're wanting to do is train those brain waves to be smaller. And so at least 80% of the time, they have to comply. They have to stay within the threshold. Okay. Whereas on the reward, you want them to get bigger. And so you want it to exceed the threshold. Yes, and different equipment and softwares have different settings. Yeah, B-Medic, to my knowledge, is the only one that does these. It's just the percentages. Everything else, I mean, the readings are the same, right? And this, looking at the size and everything is the same, but it's like a car. Okay, some people, you get in the car and in order to go into drive, you pull the shift backwards, and in some cars, you push the shift forward to go into drive. Doesn't make it any different. Okay, it's just that you got to have the numbers right. Same thing in the car. If you want to go forward and you're in one where forward is reverse, you made a mistake. And you can fix the mistake. I want to feel more confident than I feel right now, so I'm gonna really kind of noodle through that and send it out to everybody after this meeting. You'll get it before 4 o'clock today.
Thank you.
Okay. Good questions. Okay, so then did anybody get past like that initial 12 to 15? Either at CZ or at C4 when they were training anybody? What would the next step be? So if you're training, you got somebody who's over aroused, somebody who can't quiet their mind, and you're training on the right side to calm. What would you do? You did a couple of sessions. Say you did 2 sessions at 12 to 15 at C4. The first session, you went 20 minutes and you stopped. The second session, you said, well, let's see what happens if we go up to 30 minutes. You go 30 minutes. And then they come back for their third session and there's nothing. What do you want to do? You're not going to go up to 40 minutes. I'm going to tell you that. Okay. So you're going to change something in the reward band. And you're probably going to go lower. Okay, if they come back and say, the only thing that happened was I got a headache. Nothing else, I just got a headache. What are you going to do?
Would you lower it, the reward to 11 to 14?
That's a good option. And then watch to see that they don't get a headache with that training. If they come back next time and you lowered it and all they have is a headache, I'm going to add a little bit of T3 minus T4. If they come back and they say, I have nothing, you lower nothing. 30 minutes, nothing. No headache, nothing. Okay, then you're going to lower it. What if they come back and they say, I was up till 4 o'clock in the morning. I could not get to sleep. Lower it. Okay, that's over aroused. I can't get to sleep. What do you mean you couldn't get to sleep? My mind was busy. I couldn't stop thinking. My body wouldn't stop moving. They're describing over arousal. Okay, what if they say, I cried all afternoon after the training?
You'd raise it?
Yeah, you probably go back to CZ and maybe raise it. And be careful, be slow. Don't feel like you gotta, jump off the cliff, but go back and raise it 12.5 to 15.5. Okay, and all along you're really informing them about why you're doing it. Okay, so think about I always think about the dentist, right? If I go to the dentist, I want him to tell me exactly what he's doing, right? I don't like to go in and he checks my teeth and then he's like, okay, we got to pull that tooth out. I'm like, wait a minute, what happened in between? Tell me everything in between. Okay, so, and I'll tell people I have options here. I could raise it where we trained, but that is not an option I want to recommend to you. Okay, I want to recommend we go back to CZ and we're going to raise it a little bit because you're telling me that, you felt too low in your terms. You were crying, you just felt too blah. And so we just quieted your brain too much and it lost its inhibition. Okay, this happens with alcohol, right? If alcohol is a depressant, some people, when they drink too much, they start crying, they get sappy, right? Because they're disinhibited.
So if you, okay, you said that if there was nothing about the third session, you would lower the reward to 11 to 14. If they had a headache, you would do T3, T4.
I would add it.
You would add T3, like 5 minutes of that at the end.
Mm-hmm.
And then what would we set the filters for that?
Oh, good question. Okay, so if you have gone down to, if you're getting any benefit where you lowered it to 11 to 14, then keep that 11, 14 at T3 minus T4. So in other words, you don't want to be lowering on the one hand and then raising on the other hand.
Okay.
Going back, meaning raising, going back to the 12 to 15. Use the guide that you have on the right side.
Okay.
Unless you've really worked yourself down low and low in the reward band. If you're down all the way to like 8 to 11, you don't want to train T3 minus T4 at 8 to 11. You want to stay in that range of somewhere between 11 to 14 or like 13 to 16, because there you're working for stability.
Okay. And then you said the fourth session, if there was nothing, you would lower again from 11 to 14. So would that go, if you lowered again, would that look like 8 to 11?
More likely 10 to 13.
10
8
to
to
13.
11 is a little bit of a jump. And
Okay.
a cautious person would go 10.5 to 13.5.
Okay.
And that's where I think the client comes into play. Okay. Usually if somebody's not feeling anything, they're going to usually, if I'll say to them, we've been lowering, I can go very cautiously and just lower it like half a step, or I can lower it a whole step. A whole step is not, it's not a crazy, outrageous change to make. But if you're feeling particularly cautious and you want to take this slowly, we can go a little slower. And then you would lower it 10.5 to 13.5. I don't think they teach this a lot when in the general course. It's not part of the blueprint, but I think the clinical aspect of empowering the client is important. Now, you can't empower them to make decisions that they don't understand. So in the example I just gave you, both of those choices are good choices. Okay, and you can kind of weigh, this client is impatient and they're not sure they want to stay invested in neurofeedback. In that case, I would say to them, look, you're questioning if this works. If I go by half a step, you may not see results as quickly. I can go a full step and you may see more effect from the training. Got to caution you, it might be a little bit too much effect. It's not going to make you into an incapable person, but just let's decide. Are you feeling like you want to go slow and you don't mind waiting, or you feel like, no, it would be okay to feel a little bit of an effect, even if that's a little bit uncomfortable? What might that be? That might be that you have a little bit of trouble falling asleep tonight. That might be that you feel a little bit more lethargic than you usually do. Okay. And you might even say, I would recommend this, but I'm happy to talk with you about it.
I have a question. In terms of like the headaches with clients, what if they're like, oh, I'll take like a Motrin or Tylenol or something before a session or after a session? Wouldn't that be difficult for us because it wouldn't give us feedback?
Yes. Yeah. I just had a young girl come in the other day. Yesterday, she came in and she's like, how you doing? Oh, I had a headache, but it's getting better because I just took a Motrin before I came. I was like, okay. So, and she's a bright kid. She's like 16. She knows a lot about herself. And I was like, so what's happening here then is you took a medication and we're looking for the same effect that medication has. So now we're like taking another medication. So you took the Motrin and now we're going to see if Tylenol helps. It's like, we got what we got. We're going to live with it. But going forward, let's work together on this. Yeah. And you will get people that cancel appointments because of headaches. They're coming in for headaches and then they cancel because they have headaches. No, don't do that. Okay. Please, if you have a headache, come in. That's exactly what we're here for. Okay. So
their headache wouldn't, like, let's say if they come in with the headache, their headache should improve after they leave the session.
Yeah. Yep. Yeah. Yeah. People get pretty lax about telling you if they have taken any medication, if they've changed any medication. So you really need to teach them. Even if they've gotten a new medication, they just forget to tell you. And definitely don't start a new medication and change the neurofeedback protocol at the same time. Okay. Is anybody a couple of sessions into working with somebody, doing some training, practicing? How many sessions did you do with your husband? Is it your husband or your boyfriend? I forget.
Who, me?
Yeah, your kid's father.
Oh, my father, my husband.
Okay, I forgot if you were married or not. Okay.
Yes.
How many sessions has he done?
Not much. We've been slow because I'm working full time, but so we did 1.5, so not much.
Okay. Okay.
Yeah.
Is anybody else further along with anybody? A few sessions in. I know Ginny's done a bunch. Do you have any cases that you're thinking about, Ginny, or that are?
So I was just thinking about what we were just talking about with, somebody who's over aroused, and there's somebody that I started working with who actually can sleep for 10 or 12 hours at a time, which might make them seem like they're under aroused. But when I talk to them and ask them about, like, how's it going in their mind? What's happening? Do they have worries and things like that? there's a lot of intensity going on in their brain. And so the last time we met, I said, it's kind of hard. It might be kind of hard to tell because here you are sleeping a lot and you don't feel like you have a lot of energy, but your brain is really working really hard. And it might be that you're sleeping a lot because your brain is so tired from all this extra intensity. And the first time that we trained, I followed, because I had reviewed Mitch's that protocol that he's putting in. So I followed that just to see what would happen. And during the session, lowered the reward. So 12 to 15, and then I lowered it to 11.5 to 12.5. No.
14.5.
Yeah, 14.5. And so the same person became really emotional and said, I'm really uncomfortable with this. And so we had trained a bit and then we just stopped because I didn't want them to be worn out from the training, right? Or to be worried about it. And I said, there are things that we can do to adjust this. Just take care of yourself now for the rest of the day. And she came back and said, I cried and cried, but I didn't cry the whole night. And then I felt better. After I finished crying, I felt better. So when I started with her again, I said, let's just try where we stopped and see what happens.
Mm-hmm.
If you become really, and we talked about the importance of actually expressing emotions. This is a person who has panic attacks. And I know that lots of people that have panic attacks have built up emotion. They don't let that out. And so she's uncomfortable with doing that. So we talked about the importance of letting emotion out, and then trained again at 11.5 to 14.5, and she did fine. But it can be misleading sometimes when you're looking at symptoms thinking, well, maybe this person's under aroused, but perhaps they look under aroused on the outside, but they're really over aroused on the inside.
Yeah. I think if you can keep in mind the difference between me and Mitch, we're exact opposites. He's over aroused, and over aroused people tend to block out. Okay. And the way I can block out is I'm just going to pull away and manage what I got going on in here. Whereas under aroused people can be, I'm going to fall asleep. I got to do something. Got to do something to keep myself going. Okay. I got to move around a little bit. I got to have a pen in my hand. I got to stay engaged. Okay. At its worst, okay, or at its most obvious, you've all seen, I can't do it very well, but these people, they'll sit there. Can you see my knee? They like bounce their leg the whole time they're talking. It's like, how do you do that? Okay. That's like a mechanism. It's like, let's keep that motor going so that I don't fall asleep. Okay. So that's a tricky thing with that ADHD. You get kids that can't sit still. They can't sit still. They're moving to keep themselves engaged. Okay. Fidget toys. Beautiful example. I'm going to move so that I don't drift away. Okay. Yeah. It is. And that was, I want to use the word bold of you to do that. Not crazy, but it took some guts, didn't it? It took a little bit of, and work. And you see how nicely she worked with the client on that. Let's try it. Let's see. There's a lot of encouragement there, but it's kind of like, ooh, you kind of jumped into the deep end a little bit. Didn't entirely make sense, but it was a good plan.
She's obviously really responsive. And I said that to her. This is actually, I know this is uncomfortable, but this is really a good thing because it's showing us that your brain's going to be responsive to neurofeedback.
Right. Yes. Yeah. Always can frame it in a way. This is good.
I wonder, now or later, another time, if you could talk a few minutes about how to handle when people become sleepy during a session, like somebody that's over aroused, then becomes sleepy. I've been kind of hanging in there with that, but I'm wondering if I shouldn't be making some other adjustments, because the idea is to help them sleep better, but not in this very moment. They should be awake, right?
Yeah, so you've got somebody that is not sleeping well because they're generally over aroused. Okay.
Well, we can use me as an example. That's true for me too.
Okay.
And that's not only happened to me, but it has happened to me when I've been training myself, and then I become like, I almost nod off. And I think, okay, so I don't know, maybe this is a good thing, but I'm not really sure.
How do you sleep after the training then? If, you know,
It can go, so more often than not, I have more trouble sleeping after the training. I sleep less, or so I fall asleep fine, but I wake up, and I could wake up anywhere between 1 a.m. and 3 a.m. And my reward is down to 9.5 to, what would it be, 12.5, I guess, something like that.
So you're training on the right side.
Training on the right side, yes.
Yeah, yeah. Have you ever done T3 minus T4 training?
I have, but not consistently. And the more that you talk about that, the more I think that would be a good idea. I do have an unstable brain. I have migraine history, and I've had potential concussions and some other things that fall into that instability column.
Yeah, so I wouldn't abandon what you're doing, but I would add it and raise it a little bit.
Okay.
You know, you might not want to raise it all the way 12 to 15, maybe 11 to 14. And then with that, you want to do what we call wide inhibits. Okay, so if I'm going to use 12 to 15 just because that's the standard, and then you would modify it if you go down to 11. But so you do a 2 to 11 inhibit and a 16 to 36. Why? Because we're trying to hold the brain in place. So what we're doing is saying, stay in that 12 to 15 range and make that big, and everything else small. Okay.
Yeah.
It's called a wideband inhibit protocol.
That's
so if you
good.
go down to 11 to 14, then you would set your low inhibit 2 to 10.
And during the session, would you make an adjustment during the session then if somebody became sleepy?
Meaning, would I add T3 minus T4?
Would you stop doing what you're doing and then go to T3, T4 if they became, okay, that's good. Because I wasn't sure what to do in the moment. Like from maybe from session to session, yes, but in the moment, somebody's falling asleep. I'm not the only one, but I do it more often than other people that I've trained.
The other thing you want to look at right out of the gate is, you know, not necessarily related to you, I'm sure you're doing this, Ginny, but sleep hygiene. Okay. So if somebody's going, we got plenty of people go to sleep at 2 o'clock in the morning, and then they come in and they fall asleep in their neurofeedback session. You know, hey, if I'm a gym and you eat a bowl of ice cream before you come, you can't be like complaining to me that you're not losing weight when you go to the gym. And so we got to work on these other things.
Yes.
So
pretty good with that. Although I did a hard lesson the other day. I went and exercised at 4 o'clock in the afternoon and then didn't sleep that night very well.
Wow. What else did I want to think about? Okay, so the first thing you want to think about is the sleep hygiene. There are things that you can do to facilitate neurofeedback. So have somebody sit on an exercise ball. Okay, it's harder to fall asleep when you're on an exercise ball. I don't so much like having somebody stand up to do the training because that starts to bring in artifact more so than the exercise ball. If people, we think people need to sit still. You don't need to sit entirely still, right? If I'm got sensors up here and I'm moving my hands, that's not going to make muscle artifact. If I'm moving my hands like this, I will make muscle artifact. Same thing, if I'm swinging my leg, I'm not going to make muscle artifact. Chances are I won't. So an exercise ball can be a handy thing to have in place.
I have a question. I'm sorry.
Yeah.
Because I'm just thinking from like the OT standpoint, just like to kind of, would it be okay with smells? Like I'm thinking I would use like a more alerting scent, maybe like citrus or something, or keep the room like really cool, things like that.
Yes. Yes. Yeah. The scents get tricky because a lot of us have people that have high sensitivities, and worst case scenario, we had one woman come in and she wanted us to change the soap in the bathroom. She, I was like, well, you can use the staff bathroom and I'll put other soap in there. She's like, no, I can smell the bathroom from the office I'm in. So that was just a tough situation. But generally speaking, I love the essential oils, but we don't use them here because of the sensitivity of people. So I don't know how you manage that, but I absolutely, I would, if you can manage that in terms of your other patients not being impaired by it, that can be helpful. Do any of you work with younger kids? Anybody here? Are you all doing adults?
I have 2 kids. They both have urinary incontinence at night, not during the day. 10-year-old, 7-year-old, and the 10-year-old is now continent all night.
Ooh. What did you train them at?
And we trained at 12 to 15 for the reward. The inhibits are 2 to 10, and then 20 to 36. The 7-year-old, I just got the 7-year-old.
Where did you train? CZ?
CZ.
Yeah, great.
Yeah.
Great.
Yep.
So just sensory motor rhythm, become aware of what your bladder should be doing.
Yep. She's pretty pleased.
Nice.
7-year-old is a little more challenging because it has taken almost 10 tries to get him to agree to sit still enough to train for, but he trained 20 minutes the other night and he wanted to go longer because I promised him a chocolate chip for every period that he trained. He's like, I want to do 8. And I'm like, no, buddy, we'll do 7. We'll get to 20 minutes. We're not going to do more because we'll wear you out. But he still has issues with incontinence.
Yeah. So building in rewards for kids is great. Again, there's all this stuff with dietary restrictions and everything. So we went away from the food, and we have stickers. They can, either have a sticker book or we just put it right on the desk where they sit and it's there every time. And they just keep filling up the desk with stickers. Little finger puppets will stick on their fingers if they have a hard time sitting still. So for Ginny's program breaks down into periods. But for those of you with BMedic, you could do it in minutes. Every 2 minutes, you get a new finger puppet. So by the time you're done, you can have a handful of finger puppets, as long as you're not like, doing this, but you can let them sit on your lap or whatever. There's lots of ways you can build in rewards. If anybody ever wants to talk about that, but it doesn't sound like we got a lot of people working with kids here.
I would just add that we play Uno too.
So
I'll try to get them to go 2 or 3 periods to start, and then we'll play Uno for 5 or 6 minutes, and then we'll go back and do a couple more periods and then do 5 or 6.
Beautiful.
Yeah.
Beautiful.
It's the only way to keep them. And actually, it's interesting because they have very high amplitude, low inhibit waves. So they're probably sleeping deeply and not waking up when they need to use the bathroom, as many kids do, because they don't have any other symptoms of like ADD or ADHD. And well, I forget what I was going to say now. Anyway, I don't know. I forget. It'll come back.
Yep.
That's great. How many sessions did it take with the incontinence? I'm just curious.
So it actually took, we did a few times before I got the frequencies that seemed like they would be the best for them. And then after that, Kensley started not having accidents in bed. After like 1 or 2 sessions, she would go a day or two, and then we would train again, and then she would go 2 or 3 days, and then we train again, and then it was like 4 days, and then it became an exception. And now it's pretty much, I mean, not that it couldn't happen, because I think it still happens with kids, even when they're 10 potentially, but she's pretty much free of urinating at night.
That's awesome.
And what you'll see as people start to, meet their goals is, like Ginny said, it'll happen for a day or two that she's remains dry. Okay. And then the 3rd day she has an episode, and on the 4th day she comes back to Ginny. So what you'll see is it'll last longer and longer, and that becomes your cue for now, instead of training twice a week, let's think about going to once a week. Okay. Now, what again becomes a discussion with the client, because, okay, you've been holding for 4 days now. If we go to training once a week, it might be that by the 6th day, you're going to have an accident. Okay. But we know we can still help regulate that when you come back in on the 7th day. So, and people will very early on say, well, yeah, I felt better, but it was only for a day. They're like, good, that's good news. Okay. And a final thought is, anything that changes, better or worse, within a day or two after the neurofeedback training, we're going to attribute to neurofeedback training. Okay. Somebody comes back and says, well, they did better, but they are 14 now. No, that doesn't count. Like last week they weren't, and this week they are doing better. We're going to count the neurofeedback for that. Okay. Just a day or two. Okay. If I have a headache 4 days after the neurofeedback training, I don't think that was neurofeedback. Okay. It doesn't all of a sudden explode. Okay. Okay. So I think, let's see, our next meeting is the 22nd, and that's a practicum. So I'll have the equipment set up so that we can look at that. Maybe we'll look at like how to look at brainwaves. And by then, if we're just gonna have that new upgrade in the B-Medic, right? So we'll be able to look at how to look at the filtered waveforms and everything. All right. Reach out if you have any questions, and later today I will get you the definitive write-up on the threshold so that I don't confuse you. Any final questions, thoughts? Okay, good to see you guys. Thanks for joining.
Thank you.
Yeah, bye.
Bye.